Good morning. I'm going to pick up talking about adolescent idiopathic scoliosis. As Bob mentioned, it's a difficult area to break into from a referral standpoint, mainly because of the pediatric orthopedic surgeons. I have the good fortune to work at a place where we get along very well with the pediatric orthopedic surgeons, and so do a lot of the complex cases together and have a nice relationship, which I think has been very helpful and very fruitful. So, talking about the basics of AIS, which I think is important to understand, as I mentioned yesterday, because of the principles that we've learned about deformity over the years from its treatment. Its prevalence, if you define it at its minimum level of about a 10 to 20 degree curve, is not low, 2 to 3%, but only about a tenth of those are curves of a magnitude that end up needing to be treated. It is, by definition, a disease of the 10 to 18-year-old patients, and about 9-to-1 ratio of girls to boys in AIS. There are familial clusters, so these are all important elements of the history and evaluation of the patient. And typically these curves, for reasons that are unknown, are right thoracic or a left thoracolumbar lumbar curve. And just I think it's been mentioned several times, but we hang films. Make sure that you look like you know what you're doing when you hang deformity films. We hang them with left on the left, right on the right, the opposite of the radiographic orientation, and we name the curves based on the convexity. So right thoracic and left thoracolumbar lumbar curves are the typical directions of these curves. If it's the opposite of that, then it probably warrants some evaluation to make sure that there's not an underlying cause. It's rare that AIS causes pain. There is this whole issue of backpacks and low back pain in adolescents, and there's like in adults, there's a reasonable low-level prevalence of low back pain, activity-related sort of thing, and that's probably not related. It's probably a true unrelated situation in a patient with AIS. And if there is significant pain in a patient with AIS, again, it would warrant a further workup to identify the source of it, because it's very rare that there is significant pain in these patients. And of course, there's several treatment options, as we talked about yesterday. Observation is certainly an option, bracing, and surgery. The genetics are important. There is an increased incidence of scoliosis in first-degree relatives, of course, particularly female relatives, so it's worth taking that history, particularly not just a history of, oh, did you have scoliosis, but were you treated, or was there an aunt in the family or a grandmother, mother or sister that was treated either with bracing or with surgery. Because there is a higher incidence. There is an association increased association in monozygotic twins, and there are probably multiple patterns of inheritance of a tendency toward AIS. The natural history, again, there's a minimal difference in comparing patients with and without AIS in back pain, disability. It's not typically a disabling condition. Cardiopulmonary compromise, which is usually one of the first concerns I get asked about by patients or their parents, is extremely rare and only in extremely large untreated curves. There's therefore no increase in mortality as a result of scoliosis. This is really the key, or one key aspect of the treatment in adolescents of patients, aside from the clinical deformity, and that is that if a curve is over this 50-degree tide marker, so at skeletal maturity, there's a significant risk of progression, continued progression, just simply from a biomechanical standpoint. Although I have several patients in their 50s and 60s with curves more toward the upper end of this that have not shown significant progression over a decade or two. But this is one concern, is that if the curve is big enough, it's going to continue to progress. Other concerns, of course, involve the risk of degeneration and back pain and disability down the road for the patient. Thoracic curves are the most likely to progress in the natural history studies, followed by lumbar, thoracolumbar, double major. I'd say that needs to be modified a little bit because the secondary degenerative changes in the lumbar curves, if there's a significant lumbar curve, can cause those to progress in sort of a secondary way after the age of 50 as the degenerative disc disease accelerates. So the reasons for treating, again, we talked about a little bit yesterday. The clinical deformity is not to be underestimated in this patient population. Adolescence is a difficult time for many kids, and anything that distinguishes, differentiates one child from the rest, depending on that child's sort of psychological makeup and social support, can be very difficult for that child. So the psychological effects are not inconsiderable in many of these children. And then, as I mentioned, the progression after skeletal maturity is another concern. So we talked yesterday about the low, moderate, and high risk for progression, and the Cobb angle and the Risser sign. So the magnitude of the curve, the age of the child, which is really another proxy, right, for the growth potential. And there's several ways to measure the growth potential of a child or estimate it, right? The growth history, the parent's height, whether or not regular menstrual periods have started, and the tide mark there is that after the onset of regular menstrual periods, there's generally 2 years of additional skeletal growth that occurs. The Risser score is shown here. You can see the iliac apophysis here. There's a Risser 3 illustrated, just divided into quadrants. The ossification starts laterally, proceeds medially, and a 5 would be a complete ossification of the iliac apophysis. And then the hand x-rays I mentioned, where we obtain just an AP hand film and compare it to the authoritative atlas to get a gender-specific skeletal age to help estimate continued growth, with skeletal age of 18 years being maturity. There is this genetic test of progression. Again, this is I think still being sorted out exactly how useful this is. We've backed off using it because of this cost. It's not been covered by, I think at this point, any of the common insurance companies in our area. But it uses multiple markers to categorize patients as low versus high risk. And there was hope, and I think still is, that this could help identify patients who have what might otherwise be considered a low risk curve, if in fact they end up being categorized as high risk based on these markers, that you might intervene earlier with things like what Dan was talking about with stapling or anterior tethering, which are essentially internal bracing without the downside of the external orthosis. When we evaluate the patients, we need to do a thorough neurological examination, again looking for anything that indicates that this is anything other than idiopathic scoliosis, including a skin exam. We look at the coronal and the sagittal balance, look at the waistline asymmetry. And I often start these, or usually start these evaluations by asking the patients or the parents in as unleading a way as possible, sort of what they've noticed. Because they'll tell you, patients with a significant waistline asymmetry will say, well, this, I'm always hitting my hip with my left arm, but not with my right. Or I notice when I look in the mirror, put on a bathing suit, that I have a waist on one side and not on the other. Look at the leg length for small curves. Sometimes something as simple as a shoe lift can be effective in preventing progression. Shoulder balance, as we talked about a little bit, is significant, and that's something that patients and parents will know. And then the Adams forward bending test to look at the posterior clinical deformity element, the rib hump, or the thoracolumbar prominence. And then finally the flexibility, lay the patient down, push on them, sort of get a sense of how flexible the curve is, have them bend side to side, and then do the full radiographic workup that we talked about. We also discussed the Lenke classification. So as we move out of the realm of non-operative treatment and into operative treatment, that's where the Lenke classification becomes important. As far as bracing, I didn't put a lot in here about bracing. There's a recent study in the New England Journal, I think last year, bracing versus non-bracing, and it showed that bracing is effective in preventing progression, and in a nice subgroup sort of analysis or looking at the patients, they were able to determine how long the patient wore the brace each day, and basically compliance or brace use also correlated with control. So we have the patients aim for about 20 hours a day if possible, wearing the brace, basically everything except for gym class or other sports activities. So in surgery, the goals of surgery: prevent progression of the deformity during adulthood, correction of the clinical deformity, which bracing does not offer, right? Bracing offers the possibility of arrest of progression, but not correction. Ending up with a balanced, harmonious spine, and part of that, of course, is having level shoulders. So there's several different options, although more and more we're turning or using just a posterior instrumented fusion procedure, doing less and less anterior surgery for AIS as we are for all spinal deformities. However, anterior instrumented fusion is an option. Anterior release followed by posterior fusion is, at least at our institution, a historical procedure. We had to actually convert this slide of an anterior release from lantern slide because we haven't done one in more than a decade. And then growth modulation procedures, and this is really a subspecialty. The growing child, the growing spine, meaning the infantile and the juvenile and the syndromic kids. At our institution, Mike Vitale basically does all of these. It's with David Roy doing some of them, but it's an incredibly difficult area of treatment. However, in the young adolescent or older juvenile patient, anterior stapling, or I think in rare cases still, some people are doing these anterior tetherings where instead of a rod, they're using a polypropylene rope basically to arrest growth without doing fusion, with the idea that down the road you can go in and cut that or remove it after growth is complete. The goal, as we talked about yesterday, or one goal with picking levels, is to keep the fusion as short as possible. So we talk about a selective fusion, and if you read through the literature, that's often a debate: when can you and when can you not do a selective fusion? And that refers really to fusion of just one curve, and so therefore the key is identifying a curve as either a Lenke 1 or a Lenke 5. So a main thoracic or the thoracolumbar curve. Those are the situations where a selective fusion is or may be appropriate. There are a couple of other papers besides just simply the classification, but looking at some of the other radiographic features that may indicate that a selective fusion would be appropriate. That includes looking at things like the relative size of the two curves, right? So if the for a thoracic selective fusion, if the thoracic curve is bigger by a factor of 1.2 than the thoracolumbar curve, that may indicate that a selective fusion is possible. Also looking at the apical vertebral rotation. These are all three-dimensional deformities, and there's a Nash-Moe a scaling system or classification system of vertebral rotation based on the location of the pedicular shadow to the vertebral body shadow on the AP films. It's worth looking up a paper from the 60s, I believe, late 60s, maybe early 70s. So looking at the rotation, and that's really a marker of the deformity that we miss on the AP and the lateral films, but pick up on imaging modalities like what Tyler was showing with the 3D imaging that's available now. And then finally looking at how displaced the apical vertebra are relative to the CSVL, right? The apical vertebra being the maximally displaced, and if the thoracic apex is much more displaced than the thoracolumbar, then that may be a selective fusion candidate. And similar criteria looking at thoracolumbar, so these Lenke 5 curves. When can we fuse just the thoracolumbar curve and not the thoracic curve? Expecting that the thoracic curve is going to improve in a compensatory manner after correction of the thoracolumbar curve, as in this patient where we did an anterior fusion. Approach selection, I think it's important to know this, even though, again, we're doing mostly, even in the 5s and the 1s where we used to do anterior surgery, we're really doing all of those posteriorly. And the reason I think that's important to understand why we used to do these anteriorly is that we could save levels. So compared to hook constructs or hybrid hook-screw constructs, anteriorly you could usually save about 1 to 1.2 levels on average compared to going posteriorly. And saving levels, of course, is important, particularly down in the lumbar spine. With pedicle screws and with derotation techniques that Joe talked about some yesterday, the length of the construct for a posterior operation now is very, very similar, if not identical, to what we can do anteriorly. So we're not saving levels so much anymore going anteriorly. In an individual patient, if we feel for some reason that we can save levels, that's when we would go anteriorly. But that's really why this has moved more and more towards the posterior, is that we can derotate these patients, probably do a better job with the clinical deformity, particularly that posterior rib hump, and therefore prefer the posterior to the anterior. But anterior is an option if there's a single structural curve, particularly these lanky 5s are nice for the anterior, stay out of the chest. For the most part. Patient should have normal or nearly normal PFTs, since there is the potential for slight decline in pulmonary function. A hypokyphotic thoracic curve would be a reason to go anteriorly, since this is generally a kyphogenic operation going in anteriorly. Need to have adequate bone quality, relative flexibility, and you don't want a very large child or any other significant comorbidity. And then on the right side, the relative indications to go both posteriorly. The main thing here is if there are multiple curves that need to be instrumented, posteriorly is generally the way to approach that. So again, indications and contraindications, thoracic hyperkyphosis, pulmonary compromise, certainly a reason not to go anteriorly. Posteriorly, the nice thing here is the correction, or one nice thing here besides the familiarity that we all have with the posterior approach is the ability to correct the clinical deformity. So with derotation, where we're actually spinning the vertebra in space, that leads to significant improvement in the posterior rib hump in particular. We can also, if necessary, and we rarely do this, but we can do a thoracoplasty where we resect the apex of usually 3 to 5 ribs that are maximally deformed to reduce that posterior rib hump. The situation in which we still do that is patients who have a real sort of razorback, a very sharp deformity where the ribs are actually deformed. And so even though you derotate them, there's still a significant angular deformity to it, even though the prominence is less. So we'll take off the apices of those deformed ribs to give a smoother contour and a better clinical appearance. Generally, we go Cobb angles plus 1 or 2 posteriorly. Beware the rule maker. It's not a hard and fast take-home rule there. I like to use more and more monoaxial screws. I rarely use fixed head screws that have no mobility. I like the ones that move in the sagittal plane. I think it stresses the screws a little bit less. I use a dorsal bony landmark technique with segmental screws. Proximally, if necessary, use hooks. I think it's important to be able to put hooks in. I don't know if we have them here on any of the instrumentation setups, but it's certainly something to look at if we do. Maybe take a few minutes today to look at some bailout procedures if you can't get screws in. And then beware the right thoracic curve, as Bob and I were talking about a little bit yesterday, the right thoracic curve with a high left shoulder, because you're going to tend, as you correct that curve, to kick that shoulder even higher. And so picking the UIV, the upper instrumented vertebra, look carefully at that proximal thoracic curve, look carefully at the shoulder tilt, and also look at the sagittal plane to the degree that you can see it on the lateral film. Sometimes it's hard to see. Make sure that you're not missing an upper thoracic kyphosis that you don't want to instrument just up to and leave unaccounted for. The LIV at the other end, define the end vertebra, the neutral vertebra, and the stable vertebra. Generally go at least to the end vertebra, and then look at where your planned or proposed LIV is going to end up relative to the CSVL. Generally like to get to at least a Lenke B with your LIV, meaning you want that lowest instrumented vertebra to at least be touched at the lateral vertebral body by the CSVL. Anything that's more displaced than that generally is going to have a significant angle at that distal junctional disc and be potentially high risk for adding on. So a couple of quick cases. A 15-year-old girl, progressive clinical deformity, bracing, minimally compliant, 75 degrees, right thoracic curve bends down to 55, a 60-degree curve bends down to 50 and change. Her upper thoracic, I don't know what happened to her, the upper bender here is 42 degrees, and moderately flexible there. So this is a double major. We went to, double major, sorry. Went to about T4 here, shoulder balance not an issue, all posterior construct, and ending with a neutral, stable level. Might, looking at the degree of the correction here, I think probably could have saved a level down below. As you see, we got L3 pretty neutral and pretty stable. It would be nice to save a level in the distal lumbar spine. This is sort of before some of the derotation systems that we have now. 13-year-old with a significant trunk shift. I don't have the measurements here. This is the case I showed a little bit earlier, a Lenke 5, flexible curve here, and one of the last anteriors that I've done. I think this was about 3 years ago or so. I'm not sure I've done one since then. We've gone to all posteriorly on these. But it's nice selective fusion. You can see there's a residual curve here that's of no clinical consequence, and so we're not worried that that's going to progress over time. And finally, it's rare to see a curve of the magnitude of this next one. This is an 18-year-old girl that had a lot of anxiety issues, had been scheduled for surgery on a couple of occasions with other surgeons, and had backed out at the last minute. Ends up with an 85-degree, very stiff curve with a significant thoracolumbar curve. And this is one of the circumstances where we end up doing a vertebral column resection in an AIS case in order to try to translate this, translate the apex a little bit, and we also did thoracoplasties here. She had a razorback deformity. The other instructive element of this case that I remember pretty clearly is that is related to monitoring. And monitoring these cases is essential, and monitoring for as long as possible is essential as well. We were closing skin. We had closed fascia. We're starting to close skin and lost our motors. Everything had been fine since then, and we sort of saw a quick loss of the motors as we were starting to close skin after a long day, and open everything up. And there was a little small piece of remnant of the dorsal vertebral body that, as we had translated the apex, had impinged on the cord and caused a loss of the motors. So we had to give up some of our correction, resect that. She ended up doing fine, but this was probably an hour and a half after we'd done our correction before we saw any change. So it's important to keep watching those motors. We do it until we're essentially on our very last layer before we let them stop monitoring for just that reason. So this is the archetypal spinal deformity, and even though you may not see much of it or build much of a practice in it, I think there's some reasons, compelling reasons to understand it. And if you have the opportunity to do this, either with orthopedic surgeons in at your institution or in your practice down the road, it certainly is a lot of fun, very rewarding, and a nice break in a way from the rigors of adult deformity surgery. Thanks.